At the outset, I would like to thank AIOC Scientific Committee for giving me this opportunity and Dr. Mamta, our Chief Instructor, for including me in this talk of ocular emergencies. My topic is central retinal artery occlusion. What next? Before going to the actual business, you must know what are the types of the central retinal artery occlusion. Retinal artery occlusion, that is a central artery occlusion, of course, is a major chunk, 60% of cases. Branch retinal artery occlusion in 35% of cases. You have retinal artery occlusion in 5% of cases, and there may be combination of both retinal artery and vein occlusion, and also cotton spots, which again a form of artery occlusion or arterial occlusion. So, and another entity is paracentral acute middle maculopathy, that is needs to be discussed later on. So far as the causes is concerned, so we have to have a cholesterol crystal emboli, that is what we call is Hellenhorst spot. It is a main culprit, and it occurs in 74% of cases. And it is a once you see the fundus, you can see the refractile minute bright and golden to yellow orange to retinal bifurcation of the retinal fascia. And another emboli is calcium emboli, is 15.5% of cases, white single non-scintillating, arising from the cardiac process. So, and third culprit is a platelet fibrin emboli. So these are the cases. Once you present your central retinal occlusion, these are the real emergency apart from the ocular emergency, because these are the patients those are harboring the many other diseases like systemic illness and neurological illness, because the mechanism of there may be chances of having the plaque embolus in the cardiac and neurological phenomena disease also. So other causes may be there, like I am going to enumerate some atherosclerosis-related thrombosis, retinal arteritis with arbitrance, including giant retinal cell arteritis, periarteritis, sachet pain, SLE, vagus, systemic diseases like diabetic hypertension. Again, these are the culprit for that kind of things. Hyperviscosis syndrome and thromboembolic disorders. Traumatic fat emboli may cause central retinal artery occlusion and angiospasm causing emeresis. There may be a history of CVA also in those patients. Raised intraocular pressure, particularly after the RD surgery, and drug abuse and smoking. All these may lead to central retinal artery occlusion. So it occurs in, this is first described by von Grafe in 1859. It is really an ocular emergency condition. It is a condition where flow of blood through the central retinal artery is blocked or concluded, and cardiac emboli is more common in less than 40 years of age. So you have to have a patient with early age of CRO must have go for the cardiac evaluation in those cases. So far as epidemiology is concerned, 8.5% cases per lakh population, and mainly seen in older adults, early 60 years, and 90% presenting at the over 40 years of age. It is more common in male, and usually it is not bilateral, but it can be in 1 to 2% of cases. So far as the classification is concerned, it is you can divide into FFA based and pathophysiologically based, which was in vogue, non-arteritic CRO and arteritic CRO. FFA based is non-arteritic CRO with seroretinal aspiring, depending as per the FFA finding. Transient non-arteritic CRO and arteritic CRO. These are the classification commonly employed, but we usually non-arteritic and arteritic CRO, we usually adopt this etiology, this classification. So far as non-arteritic CRO is concerned, you can see here this is cherry-red spots. This is a fundus picture. This is cherry-red spots is the hallmark of this disease, and pale retina. And normal, if you go for the angio, you can see the normal perfusion of the optic nerve head. You can see there is I already told that retinal artery occlusion may be there in present, so it may be aspired, and we can have a pale retina all over, and again a strip of viable retina, but the patient can be very happy. Patient can see better even despite that arterial occlusion. So this is another variety, transient non-arteritic CRO. Here you can see cherry-red spot with few retinal hemorrhages, a small patent retinal artery, and normal-looking peripheral retina. This is angiographic picture. You can see the enclosement of the foveal zone and non-filling of the artery. So far as arteritic CRO is concerned, it is very important difference between these two, because arteritic CRO is really an systemic emergency too, and you can see a delayed arterial filling with choroidal ischemia that differentiate from the non-arteritic CRO. So far as symptom is concerned, sudden monocular paleness, severe vision loss occurring over the second, pre-monitory emesis figures may be there. Rarely, purple hue of blurring due to retinal ischemia can be seen, and you can have hallucination in cases of severe vision loss associated with CRAO. Shines, you can have vision, there is sudden drop in vision, and you can have very severe visual loss. Usually up to count finger or even worse. You can have a PL negative patient if there is a ophthalmic artery blockage in those cases. So main stage is sudden painless diminution of vision with the which version suddenly. Too important, there is important point to know the better visual acuity is in patient with CRO secondary to giant cell arteritis has been seen. The presence of an embolus is usually associated with poor vision on those cases. Eye with counting fingers or worse visual pregnancy presenting within 7 days of onset and had a best potential for improved vision acuity. A spontaneous visual acuity improvement is seen in up to 25% of cases with non-arteritic CRO. Less than 10% report a meaningful recovery. So, what are the factors determining visual outcome in those patients? The duration of the acute retinal ischemia is important. So if a patient present within the 90 minutes, 97 minutes of the occlusion, you can have no detectable damage in the circulation. If circulation restored, patient may recover vision completely. But if it presents late, almost 240 minutes of CR attack, it causes irreversible retinal damage. So but the irony is that most of the patients comes after many hours of the attack. So very difficult to restore the vision in those cases. And another determining factor is what are the types of CRO causes, and site of obstruction is also play the very important role. Residual retinal circulation, how much is left in the retina, is also important to factor determining a visual outcome. And the presence of area of supply by ciliary retinal artery is because it usually supplies the macular area. So finding is so far as finding in the detailed segment, you can have apparent papillary defect and intraocular patient may be normal or high. You may see radiographic iritis. So in some few percentage of cases, like 16.8% of cases, it is basically secondary to ocular ischemic syndrome, that is carotid artery obstruction. That is it occurs in 4 to 5 weeks after the onset, and or chronic CRO patient, CRO patients. This is the fundus examination. You can see here cattle tracking, cherry red spots and all. These are the chronic cases having disc collateral and non-perfusion optic nerve ischemia and NVD. You can see FFA is important to do in those cases to distinguish between the non-arteritic and arteritic CRO. In arteritic CRO, you can have a complete ischemia of the choroidal, so that way you can differentiate and save the patient life. So far as visual field is concerned, ciliary scotoma is most common defect observed in ARG. Severe attenuation of B wave then A wave as inner retinal layers are more affected, can be seen anosity. You can see hyperreflectivity with thickening of the inferior retina. So it is important to investigate those patients. You have to have an area of investigation like CSR, reactive protein, lipid profile. In case of you are suspecting temporal artery arteritis, then go for the temporal artery biopsy, color Doppler, CT, MRI. So you have to have ruled all the systemic causes which can lead to hyperviscosity or thromboembolic phenomena, and your investigation is directed towards that. Treatment is very important, and idea of the treatment to dislodge the emboli to the lesser importance branches. So the major retina can be perfused. So once you present in time, you start digital massage to dislodge the plaque to the another branches, and you do AC anterior chamber parasensitive to lower the intraocular pressure, so that the normal ocular normal pulsation of the cardiac dislodge the plaque into the another site. IPS development in hope to okay, just 30 seconds. Retrovascular fibrinolytic agents, YAG laser embolysis can be done, or even surgical embolysis can be done later on, and it gives some vision, restore the vision in some patients. And to prevent retinal ischemia, we have to have a start carbogen inhalation. This is a mixture of 95% oxygen with 5% carbon dioxide, hyperbaric oxygen. Emergent transparanabrectomy with perfluorocarbon liquid is important and has been done. Corticosteroid, as you know, arteritic arrow, anticoagulants, like if you are suspecting another cardiac causes. So this is the treatment and protocol, and you can basic idea to lower the intraocular pressure and dislodge the thrombus from that area. Thanks for